the Medical Home Learning Collaborative. Today I'll be talking about families and how they partner with pediatric and family medicine for quality improvement in a medical home. The Medical Home Learning Collaborative is an Indiana Community Integrated Systems of Services project, the Indiana KISS project. It's funded through a grant to the Indiana State Department of Health from the Federal Maternal and Child Health Bureau. Here I have listed some of the members of our Indiana KISS executive team. Dr. Nancy Swigowski, Mary Jo Palladino, and myself work on the Medical Home Resource Team here in the state. Other members of our executive committee include Dr. Mary Ciccarelli, also of the IU School of Medicine. She works more in the areas of transition. She heads up the Kayak Clinic, Center for Youth and Adults with Conditions of Childhood. Dr. Judy Ganser is the medical director at the Indiana State Department of Health. Also from ISDH, we have Director of Operations of Children's Special Healthcare Services, Kim Minier. Also from that department, Shirley Payne. And then we have family leader Rylan Rogers. She's from Riley Child Development Center, the LEN program, and she's a family leader with Family Voices. Finally, we have Meredith Edwards, who represents the Indiana Academy of Family Physicians. So it's a true partnership. So this morning, I'll be giving you an overview about medical home. What is that? What does the patient-centered medical home look like? I'll give you some more background about the Medical Home Learning Collaborative, the project that I spoke of. And then finally, we're going to talk about this family-provider partnership. What does that mean? What is it? How does this relationship improve health care? And how can this relationship help strengthen the medical home or the primary care practice? As Kate said, pediatrics or some of our practices are also family medicine. So what is a medical home? Well, it's more than just a building or a place to receive health care. It goes a lot deeper than that. It's that relationship or that partnership that you build between you and your physician or health care provider. In 2007, the major primary care associations got together and they developed a definition or principles for what patient-centered medical home is. And I have some of those things listed here. Each patient will have a personal physician. The medical home is a physician-directed medical practice, so that physician leads a team of individuals at the practice level who take care of the patient's overall health care needs. We're talking about whole person orientation, so that physician is responsible for providing all of the patient's health care or taking the responsibility to work with other healthcare professionals in meeting those healthcare needs. Care is coordinated and integrated across the complex healthcare system. So if that patient needs subspecialty care or perhaps they need help with community resources, that physician and that physician's staff is going to help that patient get referred to those resources. Quality and safety are hallmarks of a medical home. Enhanced access to care through systems like open scheduling and expanded hours, new forms of communication. This is all part of a medical home. Payment appropriately recognizes the added value provided to patients in the medical home. This is a statement by the American Academy of Pediatrics. The medical home is the model for 21st century primary care with the goal of addressing and integrating high-quality health promotion, acute care and chronic condition management in a planned, coordinated, and family-centered manner. So we've talked about these definitions, we've talked about the AAP's statement of what medical home is, but what does it really look like? In a medical home, there's good communication during the exam. Not just during the exam, but before the visit and after the visit. So the patient is able to communicate, make a phone call and ask questions of staff, nurses, the physician himself. There's good communication, again, before, during, and after office visits. There's coordination with specialists. I talked about this a little earlier. If a patient has a special need or a chronic condition, there's good coordination by the physician with specialists and other healthcare professionals. There's a good sharing of health education, family support, and community resources. Again, for that patient who might have special needs or a chronic condition, they know where to go at the medical home to seek this information. avoiding the ER and unnecessary visits to media care, that patient knows the hours for the office when the child might get sick in the middle of the night, so that patient knows what to do, who to call, and avoid going to the ER for a fever or the flu. Another important part of the medical home is preparing for those very important healthcare transitions through the life cycle. This is very true with families with children with special needs or patients with chronic conditions, but also just for typically developing children or patients that are leaving the pediatric world and entering adult medicine. Next, I want to talk to you about our project, our 3-year project, the Medical Home Learning Collaborative. This is just one example of medical homes in action here in our state. The Medical Home Learning Collaborative is, again, a 3-year project. It's an Indiana Community Integrated Systems of Services, Indiana KISS grant. We began in the fall of 2009 with a kickoff meeting where we invited 9 primary care practices to join the collaborative. With our budget, with our grant, we were able to invite 9 more. So we have 18 practices in the collaborative. They're diverse in size, demographics, location, cultural background of the patient panel, very diverse. I've got a map here of the state, and it shows you where some of our practices are. We have a federally qualified health center here in central Indiana. We have some rural health centers. Obviously, we have some urban practices, so you can see how diverse they are and how they represent both pediatric and family medicine. So what does it take to build a medical home? I've talked about a couple of these things, but I really want to concentrate on number 3 today, engaging parent, family, and patient partners. In so many different industries, it's important to involve the consumer input. How are you doing? You need to ask the people that are using your services. So we want to engage that patient or that family member of the patient in quality improvement initiatives. Continuing with the Medical Home Learning Collaborative, I want to tell you about how it's made up, how it works. Each practice has a team. That team consists of a provider, a physician, if you will, a nurse, a medical assistant, sometimes a social worker, front office personnel. Different members of the staff come together to work on this quality improvement team. But one of the important members of that team is inviting a patient or family member to be part of the team and give their perspective as a patient. Another part of the collaborative is the annual spring and fall meetings. We have 2 meetings a year. In the spring, we meet together in conjunction with the Riley Pediatric Conference. And then in the fall, we'll have a more intimate meeting with just the collaborative, half day to a full day of topics that deal with medical home. It's a great chance for the practices to learn from one another and meet as a team. They're away from the office. They can really think about the things they want to work on in their practice. Another really important part of our project is the face-to-face site visit, and we're able to do that with the grant, with the funding in the grant. We make visits to the practices about every 2 or 3 months. These visits are about an hour in length, an hour and a half, and we're really working on their specific agenda. What do they want to work on? What do they want to improve? How can we help them? And so we'll really go in depth at what they're working on at the practice level. Another part of the visit is sharing community resources. So we will share things that are in the community that might help their patients with special needs, their patients with children with special needs. So we get an opportunity to share 2 or 3 resources. Another part of the collaborative is the bi-weekly conference call. So those are every 2 weeks. Those occur on Wednesdays during the lunch hour for about a half hour. And then on Thursday mornings, we also offer the same call to accommodate different people's schedules. So those calls are every 2 weeks. And I want to give you an idea of what types of things we're talking about during the conference calls. These are just a few of the things we've done over the last 2 years. We worked through that toolkit that I talked about earlier, really helping them build and strengthen their medical homes. So this morning, I'll concentrate on these 3 that are highlighted updates. That might seem pretty obvious there, but during our conference calls, it's a really great opportunity for the practices to share with one another. They'll talk about their successes. Perhaps one practice is working on open scheduling, and they talk about the challenges they had to overcome. And then other practices on that call can learn from some of those people's experiences. The quality improvement team meetings. I've talked about how we build those teams at the practices that consist of the provider and the nurse and the staff member and the patient partner. But how do you hold these meetings? What do you do at these meetings? How frequently do you have them? How do you utilize that experience and that perspective of the patient or family partner? And finally, leading into that family partner idea, how do you recruit? How do you identify these champions in your practice? And then it's one thing to identify them, but how do you get them engaged? How do you involve them in quality improvement at the practice level? So finally, we'll talk about the family-provider partnership. What is it? What am I talking about when I say family-provider partnership? And I know a lot of you are in social work and other areas of public health, so I'm going to try to, when I talk about the practice level, I want you to think about ways you could use some of these tips in public health, and I'll try to transfer that knowledge to public health. Family members and professionals working together to ensure optimal services. There's a recognition and respect for the knowledge, skills, and experience that families can bring to the table. Trust is a large part of the collaborative relationship. This doesn't happen overnight. It's about building relationships, about getting to know one another and building that trust so that there's an open communication. Families feel comfortable expressing themselves to the professional and vice versa. The professional can share and express themselves to the family. Cultural traditions, values, and diversity of families are respected, acknowledged, and honored. It's really important for the professional to be aware of the experiences that family brings to the table. People are very diverse, and it's important to acknowledge that. Why include families in quality improvement in any organization? At a primary care practice, at your organization that you work in currently, why include that consumer perspective or the family perspective? Well, they can offer a unique perspective on how practices work and where there might be opportunities for improvement. They don't have a vested interest in the practice or the status quo, and they can determine what makes the most sense because they are users of your practice or users of your organization. They know your services, they're using them, and they can give you a really good insight on what might be a good place to start with quality improvement. So how does this family-provider partnership work in our collaborative? Well, for one, they do participate on the quality improvement team. Often these partners are attending the QI meetings on a monthly basis. They attend these regular meetings and they offer their perspective. Sometimes they're asked to work on very specific projects. So maybe a physician has an idea, or maybe the family member has an idea to build a bulletin board in the office where the patients are waiting, and that bulletin board could have things like community-based resources. So families with special needs can see that bulletin board and go, oh, look, I could call this place called InSource and receive some special education help for my child who has special needs. So the parent or the patient partner can help with very specific projects. You can do this on a more informal basis as well. Maybe you, the physician, or you, the staff member, are working on something and you want some feedback. Maybe you're working on a brochure for the practice and you want to see what the patients think about it. So get some feedback. Email the brochure to them. Give them a phone call. And these informal interactions can be really helpful for quality improvement. Staff on our medical home team, Mary Jo Palladino is our project facilitator, myself, we are parents of children with special needs. So we might frequent the healthcare system a little bit more than some of our friends with typically developing children. And so that's really exciting to have that representation on our medical home resource team. So we have some tools that we developed to help the physicians identify parent partners or patient partners. Some of these might seem intuitive or obvious, but I just want to go through them and in your world, in your organizations, think about where you might include that consumer voice. And I'll try to translate some of these to that world in public health. I'll think about including a parent or a family member of a child or youth with special health care needs. So again, this is somebody who might frequent the healthcare system a little bit more than typically developing children. Think about somebody who can see past the needs of their own child to the needs of other children or youth with special health care needs. So there might be that family member in your practice who's a really good advocate during exams, really knows their stuff, but they might be ready to move out and be an advocate for other families as well. Somebody who's a good communicator, somebody who's able to speak up in front of a group. You want a good advocate, again, somebody who not only advocates for their own health or their child's health, but can advocate for people in their community. Someone who's responsible, somebody who's showing up on time for their appointments, someone who's able to be on time, keep appointments, be responsible, someone like that you want on your team, a good team player. So I talked to you about some of our successes in the collaborative and within the practices of the collaborative. Now I want to talk to you about some of our challenges and lessons learned during the last 2 years. We found that it was really important when you get started with the quality improvement teams to invite the patient or family partner from the beginning. Get them involved from the start. And again, in the world of public health, think about how you can involve the consumer of your services from the very beginning. How can you get that consumer input? Might be hard to do initially, but it's really important to hear, how are you doing? What are you doing well? What could you do a little better? So we encouraged the new practices joining the collaborative to invite that partner from the beginning. Who do you ask? How do you identify a good candidate for this role? And I think I talked to you earlier about the checklist for identifying parent partners. You could use some of those tips to think about who might be a good candidate. Partners and providers were unsure of their role initially. We did a lot of mentoring. We would talk to some of the parent partners over the phone, giving them ideas on how they could get involved, how they could be effective working with the physician and his or her staff. And then in turn on our conference calls and our meetings, we gave the physician some ideas on how they could utilize this really valuable perspective from the patient. We also learned about partner turnover. We had some people leave our collaborative because they moved or they had conflicts in their life with work or their personal life. So we encouraged them to think of 3 or 4 or 5 families and invite more than one to join your team. Consider more informal kinds of family involvement. It doesn't have to be this monthly QI meeting. It could be simply asking for input about a specific issue. Show them your brochure. Show them a new process that you're doing at your organization. What do you think about this? Would this work well for you? Ask those types of questions. The process of partnering takes time. It's not going to happen overnight. So these relationships, like anything, they'll take time. So be patient. And create opportunities for everyone involved at the practice to give their opinion, not just the family or patient, but your staff. They have great ideas. They're at your practice every day, and they can give you some really good tips on where to start with QI. Again, in public health in your organization, fellow staff members, coworkers might have really good ideas on how to tackle a specific issue that you're dealing with. Your annual budget. It should include payment for meaningful family involvement, or in the case of public health, a way to include that consumer voice of your services. So think about, again, we have the luxury of the grant, and we are able to give a stipend to our family and patient partners. But think about ways that, and we were telling the physicians this in our collaborative as well, when our project is over, think about budgeting for that important family involvement piece. Just a small amount of money where you could give a stipend to them when they attend a meeting, perhaps buy some gift cards to cover the transportation costs or the time away from work, daycare costs. Think about ways that you can reimburse the family or patient for that involvement. So how can you, and we're all in this room and online, we're all members, or we all use the healthcare system. So how can you become a family partner or a patient partner in your medical home with your primary care physician? It's important to be prepared, right? It's not all on the physician. It's not all on the physician staff. It's important for you to come to your appointments with a list of questions, concerns, issues that you might have for the doctor. Be on time. Be prepared. If you do have a child with special needs, if you have special needs or a chronic condition, you might need more time in the appointment. Consider letting the scheduler know that, and they can plan ahead. On a larger scale, once you've built that relationship with your primary care provider, be positive, but if you have an issue or a concern, you can bring that up to the doctor in a positive, constructive way. Give kudos when that's deserved as well, but if there is an issue, you've built this relationship, now you can ask your provider about it. Ask them on a bigger scale if they have focus groups, advisories, or like I talk about these QI teams. Think about if they have a way for you to get involved that way. Maybe there's a specific project they're working on and you could offer your expertise and help them with that. And then, again, offer your expertise. If you have a background in public health, if you have some experience in some area or arena of public health, say smoking cessation or preventing obesity or reduction of obesity, if you have some experience doing this, offer it to your provider. Say, hey, I could give this information to your patients in the form of a seminar or a bulletin board with information. Think about ways you can offer your assistance to your primary care practice. So in summary today, we talked about medical home. I gave you a definition of medical home, tried to explain what that looks like. And then I gave you some background about the Medical Home Learning Collaborative, what's happening here in our state, and more about this project. And then finally, we talked about the Family Provider Partnership, why it's important, the value it can bring to not just a primary care practice, but lots of other organizations like the ones that you're involved in public health. And we showed you how these partnerships are encouraged in medical homes. We gave ideas and tips on how to look for that parent or patient partner, somebody who's a good candidate for that role, and then how can you get them engaged? How can you help them get engaged and help you with QI work? And finally, you as a consumer of healthcare, again, everybody in this room can be a real advocate as a patient or a family partner in improving and strengthening your medical home.